let's look at the organ transplantation and the issue of graft rejection. First and foremost, what are the most common organ transplantations? Brain? No. Brain only for taking the USMLE or COMLEX exam. All organs but brain maybe. But the top organs are kidney, pancreas, heart, liver, lung, intestines, and skin. Let's look at the major types of tissue grafts. There are 4 kinds. Autografts or self-grafts are grafts from one part of the body of an individual to another site in the same individual. Examples are skin and vascular grafts. This type of grafts, they pose by far the least rejection risk. Isografts, also known as syngeneic grafts, these are grafts between individuals with the same genetic makeup or between members of the same clone. Example, clones of the animals like sheep or cows. In human beings, the best example is between the identical twins. Allografts, also known as homografts, are grafts taken from one individual placed on a genetically non-identical member of the same species. This is by far the most common type of grafts. Xenografts are grafts between different species. For instance, in valvuloplasty or skin grafting, we may use porcine heart valve or porcine skin. This one poses by far the highest rejection risk. A 55-year-old man with a history of rheumatic fever and aortic stenosis receives a cadaveric allograft from a patient who passed away comatose 2 days after a car accident. So what is the allograft? The graft between members of the same species. The day after surgery, the patient presents with cardiogenic shock. The ECG of the patient is consistent with an anterior wall myocardial infarction. Despite all efforts to manage the patient, he passes away. It is determined that transplant rejection was the main cause of his death. Mismatch of which of the following molecules is the most common cause of reported allograft rejections? HLA-A, B, and DR, HLA-A, B, and C, HLA-C, DQ, and DP, HLA-DR, DQ, DP, or HLA-DQ, DP, and HLA-DM. Let me give you the answer. We're going to cover it in more details, and I want you to lock in this information. By far, the most common cause of rejection is incompatibility of HLA-A, B, and DR. Just to know, human leukocytic antigen, HLA molecules, are the major molecules that initiate graft rejection. There are 3 classical loci for HLA class 1. These are A, B, and C. So remember, class 1, number 1, goes with one letter, A, letter B, or letter C. But there are 5 loci for the HLA-2 class. These are HLA-DR, DQ, DP, DM, and DO. Again, HLA class 2 goes with 2-lettered HLAs, DR, DQ, so on and so forth. Most HLA matching practices require a match for at least 8 HLA markers from the 2 classes, class 1 and 2. More specifically, These are two HLA-A markers, two HLA-B markers, and two HLA-C markers, and two HLA-DR markers, more specifically DRB1. To be on the safe side, the physicians may also include HLA-DQ markers as part of the mix. As a general rule, donor must match at least 6 of these HLA markers to minimally qualify for donation. Many transplant centers require at least 7 of 8 donor matches for donation of adult organs. And again, I want you to know that with this type of matching, always there is risk of rejection. These rules will help to minimize the incidences of rejections. I have a drill question. You may not have it in your book. Remember, in the same question that I just showed a second ago to you, I said a day after surgery the patient presents with cardiogenic shock. I want to drill you to see if you remember the differences between different types of shocks. I want you to tell me which of the following 4 types or patterns of response, that includes pulmonary capillary wedge pressure, cardiac output, and systemic vascular resistance. Which of these patterns is appropriate or is well matched with cardiogenic shock? Of course, if you have cardiogenic shock, you expect the cardiac output to be down, and therefore option C is not the correct answer. At least I see in 2 conditions that the cardiac output seems to be low, and I mark it in red for you to show that it is the main issue or the original issue that you see in your patients. And that one is option B and D. Of course, in option A, also the cardiac output is down, but is not the major issue or is not the initiating issue. If you have answered option B, you are correct. And option B is going to be the cardiogenic shock. Option A is hypovolemic, and because of hypovolemia, the PCWP is primarily low, that it is translated into low cardiac output. Incidentally, we also covered in the earlier videos the concept of anaphylactic shock. Can you tell me which of these 4 patterns is associated with anaphylactic shock? That one is option C, distributive shock. Next question. A 65-year-old man receives a left kidney transplant after proper HLA matching. 4 weeks later, he presents with a temperature of 102 degrees, pain or tenderness on the left lower back, and edema of the extremities and eyelids. The patient claims that he has gained 10 pounds over the past 7 days. As part of the patient's management, he is provided with OKT3 injection and monitored for signs and symptoms of cytokine release syndrome. What is the most likely mechanism of organ rejection in the patient? Antibody-mediated damage to donors' renal endothelial cells. B. Cytotoxic T-cell mediated damage to donors' renal endothelial cells. C. Cytotoxic T-cell and antibody-mediated damage to donors' renal endothelial cells. D. D cells of the donor causing inflammation of the host tissues. That one to begin with sounds stupid. And option E, response of the host to minor histocompatibility complexes of the donor. Well, of course, as you can tell, we're going to be covering the major relevant materials shortly, and this is a good starting case scenario for you. Among the given options, the best answer is option B, cytotoxic T-cell mediated damage to donors' renal endothelial cells. And of course, the test strategy would have suggested to me to begin with that maybe the best answer, I should seek it among options A, B, and C. The time onset of the symptoms is the one that points to cytotoxic T-cell mediated damage, and this is essentially compatible with acute graft rejection that happens often within weeks after the transplantation. This type of graft rejection is mediated by cytotoxic T cells, more specifically CD8 positive T cells. The T cells that cause rejection tend to recognize vessels in the graft, and they cause vasculitis. This leads to scarring and activation of more T cells and interstitial lymphocytic infiltrations. If detected early, acute rejection can be reversed, like in this case, by immunosuppressants such as cyclosporine or orthoclone. Orthoclone, or OK3, is a monoclonal antibody. So let us revisit the concept of human leukocytic antigen, HLA. In this diagram, I'm showing chromosome 6 and the area on the short arm of chromosome 6 that is colored in red is the region for HLA. And when I enlarge that for you at the lower part of the diagram, you're going to see from the centromere towards the telomere end of the short arm, we first have the class 2 region, then class 3 region, and finally the class 1 region. And for now, in this diagram, I'm showing the HLA DP, DQ, DR, and they follow each other in the same order. By this I mean DP is mostly towards the long arm, and HLA is towards the telomere end of the short arm. Then in blue, I'm showing HLA B, C, and A in the same order. Means that HLA A is closer to the telomere end, and the HLA B is closer to the centromere end of the chromosome 6. Now, in between, we have this class 3 region, and as I've said earlier, we have several of the complements, such as complement 4, complement 2, and several of the cytochromes, and in particular, the famous cytochrome P21, or 21 hydroxylase. And if you recall from endocrinology, deficiency of this one causes adrenal virilism, and also tumor necrosis factor alpha and beta genes are also located in this region. Again, let's go through this concept together. The HLA complex is located on the short arm of the chromosome 6. The complex exhibits a high degree of polymorphism, and HLA loci are extremely variable. And every day the number of the alleles increase with the new technologies in immunology. So far, let's say up until the middle parts of 2016, over 2,000 alleles were identified for HLA-A, 100 or even more for HLA-B, and over 40 for HLA-C. Again, your exam doesn't care for these numbers. I want to alert you that the numbers are increasing as time goes on. Almost all individuals are heterozygous for most HLA, the synonym is MHC, foci, and practically you can find no two individuals to have 100% identical HLA alleles. The HLA complex, in addition to encoding for the 6 classic transplantation HLA genes, present many more proteins that play roles in the regulation of the immune system, as well as some other fundamental molecular and cellular processes such as tumor necrosis factor alpha and the enzyme 21 hydroxylase. Given that the surface HLA molecules present antigens to adaptive innate cells, this polymorphism would allow the hosts to mount a much wider response to a much wider number of the epitopes and pathogens. The HLA segment of human genome is associated with more than 100 different diseases. These include, but are not limited to, diabetes, rheumatoid arthritis, psoriasis, asthma, celiac disease, Graves' disease, ankylosing spondylitis, and systemic lupus erythematosus. A 65-year-old man with a history of type 1 diabetes and hypertension has been diagnosed with chronic kidney disease for the past 20 years. 10 years ago, he was placed on peritoneal dialysis, and for the past 5 years, he has been on hemodialysis. The patient has also been on the kidney wait list for 5 years. To find a matching kidney for the patient, which of the following transplant compatibility tests is normally required prior to transplantation? Blood type matching, HLA matching, cross matching, blood type and HLA matching, or blood type, HLA, and cross matching. Actually, you want to always play the safest, and the safest appears to be the option E, and that's actually correct. All of these matching tests are required. Actually, blood type is the very first thing that you do before you make it more expensive, because that's cheaper and easier to do. And as I said, HBO and our age matching are normally the first requirements before proceeding even to HLA matching for a particular patient. Cross-matching is the final test that identifies presence of preformed antibodies in a donor's blood that would potentially damage the kidneys. This test involves mixing the recipient's plasma with donor cells. So you perform this in a lab. Practically you simulate with the cross-matching the real transplantation situation. This is the closest procedure to the actual transplantation. The extent of HLA matching between the healthy donor and recipient determines the success rate of organ, tissue, or bone marrow transplantations. With the exception of syngeneic transplants, all other transplantations require HLA matching. Do all homografts, allografts, grafts between individuals of the same species, that's allografts, require the same extent of HLA matching? As you can tell, the answer should be no. Some organs can tolerate essentially grafts better, as you can tell. So, for instance, in bone transplantation, a perfect matching within acceptable guidelines is required, whereas in kidney transplantation, a more liberal matching may be acceptable. The most common transplant by far is red blood cell transfusion. What HLA incompatibility is most often associated with this infusion? Sorry for the catchy question. Actually, the answer is none. Red blood cells are not nucleated, and they do not express MHC1 and MHC2 molecules. In order to make these proteins, MHC1 and 2, you need a nucleus. You need DNA to make these proteins and then transport them on the surface of the antigen-presenting cells or on the nucleated cells for the MHC1. The major concern, however, with blood transfusion is ABO incompatibility. In some patients, such as kidney transplant patients who may require periodic transfusions, at times leukocytic contaminations may cause graft versus host disease. This is a trivia question. You don't have it in your book, just to get your attention and somehow talk a little about medical ethics issues. Since the 1980s, many countries have passed legislation prohibiting monetary compensation for organ donation. Organ donation for transplantation has become altruistic worldwide. Means that the patients should not seek the money for it, they have to do it for the sake of being good in itself. During the past 2 decades, advances in immunosuppressive therapy has led to a greater success in transplantation and to increased numbers of patients on transplant waiting lists. Unfortunately, the altruistic supply of organs has been less than adequate, and severe organ shortage has resulted in many patient deaths. A number of transplant experts have been convinced that providing financial incentives to organ sources, such as an alternative to altruistic organ donation, needs careful reconsideration. In 1988, a compensated and regulated living unrelated donor renal transplant organ was adopted in one particular country. As a result, the number of renal transplants substantially increased in that country, such that in 1999 the renal transplant waiting list was completely eliminated in that country. Which of the following countries that country is? Canada, France, Italy, Brazil, Costa Rica, Iran, India, or Japan? I'm sure that most of you might have not guessed it, but this country is Iran. And if you are more interested to read about this paper, I've taken these excerpts, from the Iranian model of paid and regulated living unrelated kidney donations by Dr. Goetz. There are so many challenges involved in HLA identification and typing. And I'm just showing to you this diagram again, that the HLA, DP, DQ, and DR, and also B and C and A, the cells that have these genes, they first make, the messenger RNA, and then they translate it into the special proteins for MHC2, and they present the MHC2 on the APC cells. And on the other hand, all the nucleated cells, they have the genes for MHC1, and again, HLA-B, HLA-C, and A are the genes that provide information for MHC1. Just to know, human leukocytic antigen is one of the most polymorphic genetic systems in humans, and each genetic variant is able to produce unique antigenic specificity on all cell surfaces except the red blood cells, because they don't have the nucleus. Each antigen in turn can be identified by a specific T cell with specific receptors on it for identifying that particular antigen or epitope. In 1990s through 2015, the HLA matching and efforts to match at the HLA-A, B, and DR loci have had great clinical impacts on allogeneic organ transplantation in general and in kidney and bone marrow transplantation in particular. The number of HLA alleles has progressively increased since the 1990s. For example, the number of identified HLA locus genes has increased from 200 to well above 3,000, and the number is increasing on monthly basis. HLA typing techniques includes serological techniques that are antibody-based or molecular polymerase chain reaction techniques that target the DNA regions and tend to identify nucleotide polymorphism. The molecular polymerase chain reaction assays utilize sequence-specific oligonucleotide probes, SSOP, or sequence-specific primers, SSP. Details of these are not as hot on the USMLE and COMLEX examinations, though. Just have a general familiarity with these techniques. The available serological typings are low resolution. They used to be the only available techniques. What do? They identify expressed proteins on the cell surfaces. They involve antibody-dependent cell-mediated cytotoxicity or complement-dependent cytotoxicity. Presence and or identification of reactive antibodies with these assays against the lymphocytes of prospective donors is currently the foundation of cross-matching. I want you to note that PCR technique amplifies an enormous number of copies of a particular DNA sequence. Primers are short single strands of nucleotides that are complementary to the beginning or end of certain DNA fragments. Specific primers amplify a single or small group of closely related alleles. That is, they tend to identify certain patterns or motifs on the DNA. Let's look at the basic rules of HLA inheritance. I'm showing an example in here. I'm showing the two halotypes from the mother and two halotypes from the father. I've just numbered, suppose these are the gene positions for A, B, and DR. For instance, 239 is one of the haplotypes, the other one 11, 15, and 7, and for the dad is going to be 10, 14, and 13. They stand for HLA A, B, and DR. These are the specific alleles in here, and then the next strand has 3, 6, and 12. Based on random matching, I'm showing essentially the children that are the children of these two. If one of these children wants to be a donor for the other one, the question is that which of these children can be the best donor to provide organ to his or her sibling. And of course, the two that are well matched are shown in the diagram in those two squares for you. Now, the human leukocytic antigen, as I said, is inherited as a set of 3 HLA groups, A, B, and DR. Each individual inherits 2 haplotypes, one from each parent. There is a 25% chance that 2 siblings of the same parent will have identical pairs of the haplotypes. This is a perfect match. Of course, we have one perfect match in this diagram. There is a 50% chance that 2 of the siblings of the same parents will have identical pairs of haplotypes. These are half match. For instance, this boy is half matched with his sister right in here, and the haplotype that is matching essentially is this haplotype 10, 14, 13, 10, 14, 13. So this is half match. And of course, there is a 25% chance that 2 siblings of the same parents will have no common haplotypes, no match. And of course, in this diagram, they are either half match or full match. So I don't see a no match in this particular diagram or case. A female leukemic patient requires bone marrow transplantation. One of her sisters is a perfect match and is considered as a donor. However, after cross-matching, she was disqualified. What are the top 4 causes of cross-reactivity of the patient's antibodies to donors' HLA? And as you can tell, this was, as I mentioned earlier, the very last thing that you do quite often very close to the days of transplantation. You perform this on the patients, and you do it in the lab, and you try to simulate the actual transplantation situations in the lab. What are the top 4 causes of cross-reactivity of the patient's antibodies to the donor's HLA? Previous transplants and previous blood transfusions are 2 of them. The other 2 are pregnancies and past infections. It is said that cross-match is a mock mini test on the blood samples of the donor and the recipient. Why? I've already covered this for you. It simulates the actual transplantation prior to the real transplantation. Blood from one donor and recipient are mixed in the lab. If the recipient cells attack and kill the donor cells, the cross-match is considered positive. If the cross-match is negative, the pair is considered compatible, and they may proceed with actual transplantation. What is panel reactive antibody, PRA, and what is the disadvantage of using donors' tissues that have a high degree of PRA score? PRA is performed routinely every 15 to 30 days on blood of patients who are awaiting transplantation. The PRA score is expressed as a percentage from 0 to 99 and represents the proportion of the population to which the person who is tested will react via pre-existing antibodies. So as you can tell, blood and the interior sort of environment of each patient may change. And also the total pool may change. And they may get vaccinations, they may get blood transfusions. So things change over time. And you have to address these issues before transplantation. People with a higher score need to wait longer for an organ or may need more rigorous immune suppression after transplantation. Finally, let us look at the 4 types of transplant rejection. The arrow from top to bottom shows the time onset of these rejections. We have hyperacute, acute, chronic, and graft versus host disease. Just to know, there is only one of these, which is antibody mediated, and that's the one that takes place in a matter of minutes to hours. Then we have the acute, weeks after transplantation, chronic, months, and cell-mediated graft versus host disease at any time. It may be early, it may be several years. Hyperacute kind is antibody-mediated, it is immediate reaction, and happens within minutes to hours. Pre-existing antibodies and complements as a result of past pregnancies, prior transplantations, or xenografts target the donor's tissues in this case. It may be caused by accidental ABO blood type incompatibility, and this condition leads to massive thrombosis, occlusion of the graft capillaries, and causes necrosis and death of the graft. I want you to note that for some reason the liver is resistant to this type of rejection, most likely due to dual blood supply that it has, and it will keep nourishing the organ. Acute type is cell-mediated. It takes from days to weeks for it to happen, and usually happens within the first 6 months after transplantation. This is a type 4 cytotoxic hypersensitivity, involves cytotoxic CD8 positive T cells. This is by far the most common type of transplant rejection, and to some extent occurs in all transplants with the exception of those that are among the identical twins. The donor's dendritic cells, often called the passenger leukocytes, enter the recipient's circulation. T cells now target the foreign MHC molecules. This type of reaction, as we said, is cell-mediated, mostly involves T lymphocytes and macrophages. The major pathological finding is vasculitis of the graft. The endothelial cells of highly vascular grafts, such as kidney or liver, are the more commonly affected grafts. These types of grafts are often reversible with immunosuppression, such as OKT3. Chronic transplant rejection involves T cells and antibodies. It may take months to years after transplantation, and normally after the acute rejection episodes are resolved. In this condition, we get vascular fibrosis. Chronic type is a mixture of type 3 and 4 hypersensitivity reactions, and it does not respond to immune suppression in contrast to acute transplants. For graft versus host disease, we have a cell-mediated hypersensitivity reaction or response. It may happen at any time, so the time of onset may be several hours, it may be up to a few years. This is a type 4 hypersensitivity. In this condition, the graft T cells proliferate in the immunosuppressed recipients. This is very common with allogeneic bone marrow grafts or organs that are rich in lymphoid cells, such as liver. Symptoms of graft versus host disease include fever, diarrhea, maculopapular rash, hepatosplenomegaly, and jaundice. Let us dwell on the concepts that I just covered for you. Within 30 minutes after an organ transplant, the recipient rejected the transplanted organ. You expect the patient to most likely have a transplantation of any of the following organs except, well, it's 30 minutes, so it must be hyperacute, and I said earlier that liver somehow is immune in this type of rejection. The reason of it may be due to dual circulation to liver. Which of the following types of rejection is by far the most common type? If you recall what I said earlier, acute is the most common type. Which of the following types of rejection is by far the most common rejection with allogeneic bone marrow grafts? This is graft versus host. Which of the following types of rejection is a combination of type 3 and type 4 hypersensitivity? This is the chronic type. Which of the following types of organ rejection is antibody mediated? That one is hyperacute type. I want you to know that chronic is both antibody and cell mediated. The organ donors with the best HLA match are closely related siblings. It is obvious that allografts may pose more rejection risks. Given the multiple existing HLA subtypes, for practical purposes, current medical standards require matching for a minimum number of subtypic HLA markers. What is the most commonly used number of markers? I've already briefly covered this for you, but let's go through this together. A minimum of at least 8 HLA markers is required. Normally we use 2 HLA-A markers, 2 B markers, 2 C markers, and 2 DRB1 markers. A minimum of 7 out of these 8 must match before we can proceed to transplantation. So 7, the number 7 is the magic number. In some situations, some clinicians may even use 2 additional DQ markers. Of course, you can add as much as you wish, but there is a limit. We have to be practical when it comes to transplantation because the life of the patient is at stake. In certain situations like leukemia, patients may receive umbilical cord blood. The cord blood requires less strict matching criteria, and clinicians often only use a score of 4 among the 6 HLA markers. So we only need 6 HLA, and 4 is enough for go ahead. The 6 markers are 2 HLA-A, 2 HLA-B, and 2 HLA-DR-B1. And again, only 4 of them may minimally qualify as a match. Umbilical cord blood, like bone marrow, is a rich source of stem cells and is suitable for transplantation. Umbilical cord blood is in particular helpful for patients who cannot find a proper marrow donor and for patients from diverse heritages with uncommon tissue types that do not match the common registry of bone marrow, or for those who need immediate transplantation. All allogenic transplantations require immunosuppressive therapy after operation. What 2 allogenic transplants are exempt from this generalization? Cases wherein the donor and recipient are identical twins and corneal transplants. Acute rejections are commonly prevented by administration of a special immunosuppressant drug. This drug is a monoclonal antibody that targets CD3 receptors on the T cells. What is the name of this drug? I'll give you a hint. It is the first therapeutic monoclonal antibody that has been approved for use in humans. Well, we have already covered this. This is your famous orthoclone or OKT3 or muromonab-CD3. So muromonab-CD3, the brand name of it is orthoclone, and also it's known by OKT3. Despite all efforts to achieve optimal HLA matching, allografting is often accompanied by immunosuppressive therapy against what type of histocompatibility? Minor histocompatibility proteins. I want you to know that normally proper matching safeguards against the most common HLA incompatibilities. However, due to polymorphism of HLA genes, minor amino acid differences may potentially be immunogenic and less frequently can cause graft rejection. Another important issue, a classic minor incompatibility is observed in women with recurrent miscarriages after their first born male child. Look in this information. It is postulated that transfer of male fetal cells into maternal circulation causes immune response of the mother against the male antigens related to chromosome Y. Now, mothers will get immunized against male-specific minor histocompatibility antigens of their own male children. Later, this will pose graft versus host issues when these women happen to donate their organs to male recipients. A 56-year-old male patient with end-stage renal failure receives an allogenic kidney transplant. After the operation, he receives a medication that binds to FK binding protein, blocks calcineurin, and inhibits NFAT, nuclear factor of activated T cells. As part of his post-op management, the patient is monitored on a regular basis for kidney function, blood pressure, and blood glucose levels. Which of the following medications has the patient received? tacrolimus, cyclosporin, sirolimus, brand name rapamune, muromonab or OKT3, and azathioprine. Among the given options, the ones that binds to FK binding protein, blocks calcineurin, inhibits NFAT is tacrolimus. Well, again, as we said, the patient has received tacrolimus. This is an immune suppressant that is a macrolide calcineurin inhibitor. I will be talking about all these towards the end of my lectures. Tacrolimus has a similar mechanism of action to cyclosporin, but it has a different structure. It binds to FK binding protein that is functionally related to cyclophyllins, and the complex blocks calcineurin. As a result of blockage of calcineurin, NFAT activation is blocked. Major side effects of tacrolimus are nephrotoxicity, neurotoxicity, hyperglycemia, and hyperkalemia. Note that cyclosporin blocks signaling for interleukin-2 transcription by binding to cyclophyllin. Cyclosporin-cyclophyllin complex then binds calcineurin and blocks calcineurin activation. This results in blockage of downstream activation of NFAT. Also note that like tacrolimus, it causes neurotoxicity and hypertension. I want you to note that sirolimus, unlike similarly sounding compound tacrolimus, so watch for this because they are similarly sounding, but they have different mechanism of action. Sirolimus is not a calcineurin inhibitor, but it has a similar suppressive effect on the immune system. Sirolimus inhibits interleukin-2 and other cytokines receptor-dependent signal transduction mechanisms via action on mTOR. mTOR is a serine-threonine protein kinase, and thereby blocks activation of T and B cells. Tacrolimus and cyclosporin inhibit secretion of interleukin-2 by inhibiting calcineurin. Muromonab is a monoclonal immunoglobulin G2A antibody. It binds to the T cell receptor CD3 complex, specifically to the epsilon chain of the CD3. This happens on the surface of the circulating T cells. Initially, it leads to activation, but subsequently induces blockage and apoptosis of the T cells. Therefore, muromonab inhibits T cells. I will cover all of these in more details with diagrams for you later. For now, I just wanted to orient you.